Session 2 is entitled The Science Behind Addiction. And we will have Dr. Vanta Green tell us more about the science behind addiction, the genetic factors that play a role in substance abuse. Certainly, I have two grandparents who are both alcoholics. On my mom's side, my mom was what you call the adult child of alcoholics. She was a superhero, non-drinker superhero. She served 6 terms in Congress, was the highest ranking Republican woman in Congress. But those genes somehow jumped right on down to the grandkid here. And that's why I struggled with alcoholism and continue to be in recovery today. And so Dr. Green, Banta Green, is a researcher at the University of Washington's Addiction, Drug, and Alcohol Institute, where he worked for more than 20 years. He partners closely with King County local, state, and federal government and community organizations to provide accurate information and data about substance use disorder, and of course, effective interventions. Dr. Banta Green, thank you so much for being here today and your willingness to share your expertise.
Great, thank you for inviting me. So it looks like maybe my slides are going to be advanced for me, which is lovely. So I am at the Addictions, Drug, and Alcohol Institute. I also am affiliate faculty in the School of Public Health and the Harbor-V Injury Prevention and Research Center. And I just mentioned that because it gives you a sense of the different types of impacts that alcohol and other substance use can have. So next slide. So very important. I'm not going to get a lot into medications, but important, I do not accept funding from pharmaceutical companies. I do not have any conflicts of interest to report. I mention these funding sources in part because I want to give you a little bit of perspective on where I'm coming from in my work. The work I'm doing with the Washington State Division of Behavioral Health and Recovery is I oversee a team of a half dozen clinicians providing technical assistance to those who are part of these opioid treatment networks across Washington State, including in King County. There's over 24 networks with over 150 providers. We've been supporting them for over 3 years, and just incredible lessons learned about new models of care, about needs in the community, and how do you staff all of this? How do you do this no wrong door thing? So that's really exciting work. I work with a colleague, an infectious disease doctor at Harbor-V, Dr. Joanne Steckler, around PrEP, HIV prevention medications for those who use methamphetamine. We partner with King County on a SAMHSA grant to help do more work around opiate overdose prevention and education. I have a Pew Charitable Trust grant to help evaluate a low-barrier Pew clinic in Olympia. And then my largest grant right now is from the Paul G. Allen Family Foundation, along with other supporters, including Premera, the Healthcare Authority, and Seattle Foundation. And that is a replication study of low-barrier buprenorphine that began in January 2017 in Belltown. It was an idea that I pitched probably 7 years ago now, and Mr. Finegood found the financing for, and we launched this pilot project that I'll mention in a few minutes, because a lot of important lessons learned there, not just about how to treat opioid use disorder, but how do we treat substance use disorder and behavioral health conditions all together. So I'll talk about that a little bit. Next, please. So I'm going to talk about a lot. Don't worry, I can talk fast, and you can also have these slides. And all this information is on our webpage. So why do people take alcohol and other drugs? What is addiction, use disorder? What factors increase the risk of use disorders? Do people really not want treatment? That's probably one of the most important things to talk about today. What is recovery? And then to share some of the new approaches that are getting used locally. Next, please. So why do people use drugs and alcohol? This is, if we were all in a room together, we'd probably have an hour conversation about this. This is the Cliff's Notes version. Obviously, there's strong social and peer influences for many people. Most use of substances begins before the age of 25, before our brains are fully developed, and those social and peer influences are particularly strong at that point in time. There are mental components, medical components, emotional components. Anxiety and depression are extremely common. And very much related often to how people use and reinforce use of substances. Pain, emotional and or physical pain, conditions such as attention deficit hyperactivity disorder, and so on. I also think it's really important to acknowledge that drugs and alcohol feel good. To not acknowledge that, I think is going to make many people disengage. If you don't acknowledge that, at least at the front end, at least at the beginning, substances feel good. There's a high euphoria to it. Eventually, though, while you may start to use to feel good, many people end up using to not feel bad. And that's really kind of the cruel irony of a substance use disorder, is it really becomes a coping mechanism for bad feelings or for a withdrawal. And for many people, the reasons are not overt, clear, or purposeful. I think the most important thing to say is there's no guilty or innocent victim or person who uses substances. No one starts using and says, I want to go onto a lifelong path of addiction. And I think that's really important to acknowledge. Next, please. So what are substance use disorders? And this is some language that's somewhat adapted from the National Institute on Drug Abuse. Many people mistakenly think that those who use substances lack moral principles or willpower, and that they could just stop their use simply by choosing to. That's really important to understand. That's really a predominant belief still, despite 50+ years of science. That really indicates that addiction is a complex disease, and quitting usually takes more than good intentions or a strong will. Substances change the brain in ways that make quitting hard, even for those who want to. The good thing is we actually are really good science about how substances affect the brain, and that there really are a number of different treatments that can help people recover from alcohol and drug use and lead productive lives. So next. So it's a chronic disease characterized by seeking the substance and use that is compulsive or difficult to control, despite harmful consequences. I'm going to come back to that in a minute, because I think that's a really important piece to understand as we think about our policy and clinical responses. The initial decision to use is voluntary. For most people, except in rare instances, it's a voluntary decision. But the repeated use can lead to brain changes that challenge our self-control and interfere with our ability of our brains to resist intense urges to use. These brain changes may be persistent, which is why addiction is considered a relapsing disease. The head of the National Institute on Drug Abuse talks about alcohol and drugs really hijacking the reward system of the brain. From the outside, it looks like a person is making bad decisions. From the inside, you see that a person's priorities in life have literally changed. That food, love, water, sex, those have all bumped down a priority list, and that substance has now become number one. And that's not a thing that they wish for. It's not a thing that they can intrinsically control. And you can't see it from the outside. So it's this real confusion about the behaviors that a person is manifesting versus what's actually driving those behaviors when we look inside. And we'll talk more about that. Next, please. So it's very common for a person to return to use. As Councilmember Dunn just mentioned, relapse doesn't mean that treatment doesn't work. It often means that you need to either change it or actually turn it up. As with other chronic health conditions, treatment should be ongoing and should be adjusted based on how the patient responds. When I did my training more than a quarter century ago, it was too common to say, you have this type of addiction, you fit in this slot, you're going to get this type of treatment for this long. And we found over and over and over that that does not work. It really has to be titrated to effect or adjusted to a person's needs in the moment. Too much treatment can be just as bad as too little treatment. And we have to be mindful of that and not take a one-size-fits-all approach. Next, please. So each substance has separate diagnoses, but within this DSM-5 criteria, which ranges from mild to severe, here are the core components. And I want to take a little time here to talk about this. Taking more of a substance or longer than intended. A person tries to stop and cannot. Lots of time is spent obtaining a substance, using it, and or recovering from it. Craving, really just this intense urge that persists and often really kicks out other thoughts and desires in a person's life. Work, school, or home obligations are not met. This is what I want to return to. A person keeps using despite bad consequences, both physical and psychological. And that's really important because oftentimes we think we're helping by letting a person hit rock bottom or by giving a person severe consequences. But the point is that a person definitionally with substance use disorder keeps using despite bad consequences. More bad consequences does not support or help a person stop using. It just creates more harm. And we have to be very thoughtful about how we effectively use our resources. Other aspects of substance use disorder, important activities are stopped or reduced. People use in dangerous situations, particularly driving is what we think of the most, but there are many other situations as well. Tolerance and withdrawal. I can't see anything because the chat's in the way. Tolerance and withdrawal. So this is very important. As people use substance over time, They need more to get the same effect. And with many substances, if they stop using, they can go into withdrawal. With alcohol or benzodiazepines, that's potentially life-threatening withdrawal. It requires medical detoxification. With opioid use disorder, it's painful withdrawal. With stimulants and cannabis, they can be more likely to be agitation and depression types of withdrawal symptoms. So this idea that over time, a person needs more to get the same effect. And when they stop using, there are different withdrawal syndromes depending on the type of substance a person has used. Next, please. So really important to keep in mind, this is very important, not all substance use is disordered. I think we all know that when it comes to alcohol, right? Many people use alcohol in non-problematic ways. It's also important to acknowledge just as much that many people use drugs in non-problematic ways also. I think it's important for people to remember that a lot of the consequences of drugs are due to societal choices. You may recall that during Prohibition, alcohol was illegal. We've also had a phase in our United States history where heroin was legal. So we need to separate out the effects of the substance itself from the consequences that we as a society choose to enforce upon certain folks. And this addiction potential of these substances varies, as do the health, social, and legal consequences. And we have choices over some of those, maybe not the health ones, but the social and legal consequences we do have choices about. Coerced treatment is unnecessary and obviously not appropriate for people with non-problematic use of alcohol or drugs. That sounds obvious. Yet, oftentimes when we think about, well, we're not going to incarcerate a person who uses substances, we're going to put them in treatment. Well, it doesn't make sense if they don't have use disorder. And one of the most important things that I will share with you towards the end here is you do not need to force people into treatment if you create services that people actually want. And we are learning and seeing that over and over and over again. And that's the most important thing I hope I can share with you today. And I will come back to this in a minute. So when there are alternatives to criminal penalties, and we're thinking about that, it's necessary to do shared decision-making, ask that person what they want, what services they are, educate them about their condition, tell them about the treatment options. Then they get to make that choice about their care. And then we also need to be thinking about the other things in people's life. It is almost never that a person just has substance use disorder. There are other things going on in a person's life, whether there's social factors, mental health factors, and so on. And we have to be addressing those as well. Oftentimes addressing the social or life circumstances for somebody is going to be the more direct, immediate reward than going after the substance use itself head on. So we're really looking at comprehensive services, whole person care. Next, please. So coming back a little bit to this NIH language, most drugs and alcohol affect the brain's reward circuitry. They cause euphoria, as well as flooding it with chemical messengers such as dopamine. A properly functioning reward system encourages the person to repeat behaviors needed to thrive, such as eating and spending time with loved ones. But as I said earlier, this surge of dopamine and other transmitters in the reward circuit cause the reinforcement of pleasurable with unhealthy behaviors like taking drugs, leading some people to repeat those behaviors over and over again. What does that mean? Again, to the same point, we generally are motivated to do positive things, and that's how our neurotransmitter system is set up. And it's reinforcing us doing those positive things. But many substances and some people can actually hijack that system and actually lead to all of those drivers that we think are around survival are now turned from things that are related to survival, such as love and food and water, to drugs. It is literally a change in brain chemistry that you cannot see from the outside. And a person may not even realize it's happening on the inside, but it is driving so much of people's behaviors. And we need to recognize that when we think about care. And what you can see here is an example of, this is just one example. On the left side here, this is a sort of typical normal brain. And the areas that are lit up in red is the dopamine transporters. And this middle slide is someone who has a person who has long-time methamphetamine use. And this is a month after they've stopped using. You can see that red area, those dopamine transmitters are severely affected. There's very minimal response there. There's a long-term cognitive impairment for folks who use methamphetamine, as well as other substances. But what you can see in the image on the right side is that dopamine system can recover and it can come back, but it can take a long period of time. And that matters for two reasons. One, it means that if you look at the brain in the middle, a person who is recently or currently using substances, we need to be making sure we're matching services that match their capacity to engage with them. Doing intensive psychoeducation or workforce training for a person with severe cognitive impairment makes less sense than really supporting that person socially and interpersonally. And working with that person over an extended period of time, 1 to 2 years of extended service is often what is needed. And then a person can eventually start taking on other activities to start building back their functioning in different life domains. Next, please. So to the question that was raised earlier, why do some people become addicted and others don't? There is no one factor that predicts if a person will become addicted to alcohol or drugs. It is a combination of things. It's biology and genes. They can have a strong, they have a strong, although probably a minority impact, but a substantial proportion is driven by biology and genes, but not for everyone. Environment is incredibly important. Trauma is incredibly important. There are a lot of learned coping mechanisms as well. So there's these biological drivers, as well as a lot of environmental and psychological drivers. From a developmental perspective, these genetic and environmental factors, they interact in these different life stages. And as I mentioned, the majority of folks with substance use disorder began using before the age of 25, when their brain is still developing. And they essentially end up with the fancy phrase is sort of maladaptive coping mechanisms. What that means is that rather than often being able to use cognitive and emotion calming internal processes to manage behaviors, to manage stressors, they start reaching to external things such as alcohol or other drugs to help them manage uncomfortable feelings, physical or psychological, which is one of the reasons we really talk about delaying substance use as much as possible. And again, the more risk factors a person has, the greater the chance that using alcohol or drugs can lead to addiction. Next, please. This is super important. I've hinted at it earlier. Despite what we may hear, see, or believe, most people with substance use disorders do not want to be using substances in harmful ways. I'm going to show you a little bit about that. Next, please. So I've worked with Public Health Seattle King County for over a decade with their syringe service program survey data. And this survey is actually, we expanded in 2015 to the entire state, which also includes King County. This is almost 1,300 people surveyed in 2019. And we asked folks, and this is going to focus on heroin and methamphetamine, two major substances we look at. Are you interested in stopping or reducing your use? This is for opioid users. What you'll see here on the left side of this upper graph, 82% of people said they were very or somewhat interested in stopping or reducing their use. The majority of people, the vast majority of people. Also note the language. As someone who has worked in addiction treatment and talked with many people about it, we didn't ask them, do you want treatment? That is a completely different question. It's a very loaded question. What I want to know is if a person wants to stop or reduce their use. Without that, we can't get to the next point. So 82% of people say they want to stop or reduce their use. We then ask them what services they would want if they were easy to get. Number one, methadone, buprenorphine, or naltrexone. By far the most evidence-based interventions we have. Also interested in detox, more interested in detox in areas of the state without good access to medication. So that's important to know. Many people are interested in counseling, care navigation, inpatient, outpatient, mental health medications to address their opioid use disorder. What's important here is 82% of people want to stop or reduce their use, and only 2% don't want any help to do that. That is the vast majority of people. 98% of people want multiple supports to help them reduce their use. We need to ask them, and we need to offer those services. And then on the next slide, you'll see some interesting similarities and differences with methamphetamine. So for methamphetamine, 48% of people wanted to stop or reduce their use. So a much smaller proportion, but still a sizable proportion. And I'll talk a little bit more about that. But one of the issues with opioids is you talk with people who are using opioids and they have use disorder. They're using to not feel bad, to not go into withdrawal. We call that negative reinforcement. So people don't like that. With stimulants, there's a lot of positive reinforcement. There are a lot of positive things they get out of it. It gives them good energy. It allows them to focus. It helps with depression. It staves off hunger. These are good things probably generally for a lot of people, and they're particularly good in the context for folks who are unhoused. So we need to recognize those drivers of use are going to be essential to address, very likely before you even get to addressing the substance use itself. So what were people interested in? Counseling, a medication that might help reduce use, navigation, outpatient, mental health meds, inpatient. Again, the point here, most people are interested in multiple things. So I think a lot of times, and I literally am stepping into this meeting, there's a day-long NIH meeting talking about methamphetamine and fentanyl right now. What's really important is a lot of people throw their hands up in the air when it comes to methamphetamine. It seems so problematic. It seems so untreatable. People are sort of presenting in such troubling, externalizing, outward, antagonizing ways. If we can give them a safe place to be and a safe way to relate to people and a kind way to relate to people, and they can gather their wits about them, we give them the time and space to do that, and we start offering services, people will engage. We just have to completely change everything we do about how we care for people, because our standard treatment system and our standard healthcare system could not be worse for people with stimulant use disorder. Next. Counseling and social support groups. Many people like, want, and benefit from these services. They can be invaluable for many people, but not everyone. And it's not because they're in denial or don't want to stop or reduce their use. It's because they aren't necessary or beneficial for many people. They're wonderful for many people, but they're not right for everybody. The default assumption about what is effective treatment that I've learned in my talks is the general public thinks that treatment is 12-step, inpatient, and detox. And that is the case for a minority of folks, not a majority of folks across all substances. Those are important tools, those are important resources, but there's a lot more to effective treatment than just those interventions. The quality and appropriateness of these services is highly variable. There are really high quality services and there are really low quality services. For some substance use disorders, the benefit of the psychosocial supports may be modest on average. That's particularly true for opioid use disorder, where we have such effective treatments with the medications buprenorphine and methadone. And I'm a social worker. I love talking with folks, but I want to talk with folks who want to talk to me and for whom it's beneficial, not who are mandated to be there and for whom it's counterproductive. A lot of people with substance use disorder have a lot of anxiety, a lot of social anxiety, and forcing them to go to individual or group counseling can be counterproductive and in fact lead them to leave treatment, not because they don't want to stop using, but because the types of treatments we're using are aversive to them. And in all of this, we need to understand this is a medical condition, and medical providers should always be part of the care team that's consulting around what evidence base is needed. Next, please. So what is recovery? This is a whole other big long conversation, but I think we need to focus on recovery is about recovering a healthy level of functioning. Some people continue to use substances and some don't. And that's true whether we're talking about alcohol or other drugs. Oftentimes people think of recovery as abstinence, and for some people it is, and for other people it's not.